Well, hello, everyone. I'm Dr. Allison Kelly Hedgepath here with Dr. Dara Lee Lewis, welcoming you to our monthly or bi-weekly webinar series. So thank you for joining us today. I hope everybody is doing well and Happy New Year. And we are really excited to be joined with our guest, Dr. Eric Zhou today, and Dr. Bilchek is joining us as well. Dr. Zhou is a clinical psychologist who has expertise in treating insomnia. And he and I met because we've shared a number of patients over the years that rave about his approach. And we thought, what a great way to kick off the year 2022 by talking about sleep. So Dr. Zhou is affiliated with Harvard Medical School, Brigham and Women's Hospital, and Dana-Farber, and runs a clinical practice that really focuses on insomnia and treating sleep disorders. So Eric, welcome. Thank you for joining us today.
Thank you so much, Dr. Kelly Hedgepath. This is an absolute delight and a privilege to be able to chat with you all about sleep. And it is my goal to talk quickly so that there's an opportunity for folks to ask questions, because I find that that tends to be a much better use of your time than hearing me blab for much too long. So without much further ado, let me dive right into our conversation today. So what I really want folks here to take away from this presentation is to really understand specifically insomnia, but then broadly more about sleep and how to think about what your sleep looks like and whether this is worthy of further conversation with your providers. Now, what I want to first disclose is I have grant funding from the NCI and some foundations that are related to the topic that we're going to be discussing today, and some unrelated funding from 2 pharmaceutical companies that don't relate to the work that we're going to be talking about today. In terms of our objectives, I really first want you to believe that sleep is something that will really matter for each and every one of you who gets to participate and listen to this conversation today. Next is for you to understand if you have insomnia. It's a word that gets bandied about, but is not always truly understood. And then find ways to encourage you to implement some lifestyle changes that really will matter when it comes to insomnia. And ideally, because we know that improving your sleep improves overall health, that you can then in turn improve your overall health as well. But really, I think the takeaway is I want you to think about sleep. I want it to be something that's in the back of your mind. I want it to be something at the tip of your tongue, that it's always there, present for you to contemplate, because it is so fundamentally important to your overall health. Now, whether you are a reader of CNN, BBC, Xinhuanet, sleep is all over the place in the media nowadays. It's even to the point where we've been talking with the federal government, but the Healthy People program, in which sleep health is a very hot topic. And so this is something that I'm hopeful, thinking about even before the topic of this conversation came up as a webinar. And a part of this is because we're seeing a really worrisome trend in this country. So this is data from 2014, and it continues a trend in which more and more Americans are getting less and less sleep. So this figure shows the percentage of American adults who are sleeping less than 7 hours a night. And the darker the color of the state, the more adults are sleeping less. And I suppose if we look at us here in Massachusetts, we aren't doing so hot, which is probably not a surprise for many of you if you are here at this talk. Now, I tell everyone, sleep is probably the most boring activity that you can do at night. And that's an issue because there are so many other possible alternatives that compete with sleep. And you might think, well, this is really silly, but if you actually look about 3 or 4 years ago, this was a tweet that Netflix had sent out, which I got a good chuckle out of, because the reality is it is true. Your sleep, or the opportunity for sleep, is a competition for their bottom line. And so they are doing everything they can to get you to click next episode, and your sleep really often doesn't have a fighting chance. Now, we'll start there actually. We think about what happens without getting enough sleep. It's something that's often trivialized. We laugh and we think, oh, it's just somebody who is falling asleep while having dinner. It's not that big of a deal. Well, if we look at the lay press, we see articles like this one in the Reader's Digest. America's sleep crisis is making us sick, fat, and stupid. Not such good outcomes. Well, here's another blog article that says how insufficient sleep makes you fat, stupid, and dead. Seems like an even bigger set of worries than the last one. Now, you might take away from this, these are probably clickbait articles, really no science behind this. I shouldn't really worry too much. Well, let's actually dive into the science and see what it tells us. So in 2016, these were the leading causes of death in this country. And obviously, not surprisingly, heart disease is number one, which is why I'm thrilled that all of you are in such good hands in managing your cardiovascular health here. In terms of looking at that list, let's look through some of those top 10 causes of death in this country. So first, I want to look at some data relating sleep and hypertension. So this is a wonderful epidemiological study that looked at hypertension risk and short sleep duration, and their takeaway was that over about an 8 to 10 year follow-up period, folks who were short sleepers were much more likely to actually develop hypertension after controlling for risk factors like obesity and diabetes. You're thinking hypertension, something that Dr. Kelly Hedgepeth can manage. We don't really need to worry about too much. Well, there's even more data looking at cardiovascular health. This is looking at MIs. This is data that was published not too long ago, actually. This is really interesting data in which they looked at both sleep duration as well as genetic risk factors that people may have for cardiovascular disease. So what they did was they looked at a group of people, adults, who are what they considered low genetic risk, as well as getting about the right amount of sleep. And everybody else was compared to this group. What they found was if you didn't have a genetic risk for cardiovascular disease, but you weren't sleeping the right amount, that you are more likely to have MI. Interestingly, if you had worse genetic risk, a medium level of genetic risk, but you were sleeping a favorable or the correct amount, the risk for MI was about the same as if you had low genetic risk and an incorrect or an unfavorable sleep duration. In other words, something about sleeping the right amount versus not enough can actually potentially be protective for health outcomes into the future for you. And in that study, what they concluded was that people who were short sleepers, in this case, they categorized them as less than 7 hours, that there was an increased risk of MI by about 19%. And that for these individuals, if they just could find a way to sleep an hour longer, they could decrease their risk of MI by 20%. And I would argue these are things that are pretty compelling statistics to at least think about. Now, for other things that were on that list that I had showed you earlier, well, weight gain is another one. And so in this particular nurses' health study, which is actually based out of Boston, over at the School of Public Health, they looked at weight gain in women. And what they found was in almost 70,000 women that after adjusting for things like age, baseline BMI, physical activity levels, and their diet, folks who were short sleepers were much more likely to gain weight than folks who weren't short sleepers. We see the same thing with regards to risk of motor vehicle accidents, respiratory infections, in this case, head or chest cold and infections. And so if we go back to that first thing that I showed you about top causes of death in this country, we can reasonably see that for many of these issues, that insufficient sleep either causes the development of or the exacerbation of many of these comorbidities. And so hopefully what your takeaway from this is to say, boy, we've got to think about sleep because it has such an important impact beyond just, I feel drowsy the next morning. Now, I do want to catch myself there for a moment because all of that data is primarily from epidemiological studies, meaning that we're studying huge portions of the population in the United States or around the world. And why so many of those studies are epidemiological is because we need a number of events to occur. Like, for example, we need people to gain weight. We need people to have myocardial infarctions to happen in enough numbers to be able to tell, well, if short sleep really relates to these things. And the limitation, however, of doing these big studies is you can't ask 70,000 women across the country a really detailed assessment of their sleep. So often, the best thing that we can do is we ask them about how much sleep that they get. That leads to a lot of news reports about needing to get more sleep. And I don't want that to be the takeaway for the group today. I want you to understand that getting the right amount of sleep is the right answer, not necessarily more. And in this case, why I want you to think about this is a metaphor I can draw with diet, for example. No one sits there and says, you know what, I need more food ever. What you really want is the right amount of food at the right time of day, which is actually what leads to this tri-model related to sleep. So first piece is insufficient sleep. That's an issue, of course, that we want you to think about as we've discussed previously. But in addition to that, another equally important issue is fragmented sleep, which means that your sleep is interrupted over the course of the night repeatedly. And the final piece of this is dysregulated sleep, meaning that sleep doesn't occur at the same time of day every day, or is varying in terms of how long it is between different days. What you really want in terms of having good sleep quality and not poor sleep quality is all three of these pieces in sync, not just the quantity piece, which we have talked a lot about since that's where a lot of this data is coming from. So with this in mind of wanting you to get sufficient sleep that's not fragmented and that is consistent, that's going to be the focus and our goal for the rest of this conversation. Now, what can cause any one of those three things not to be good? Well, there's a lot of sleep disorders. It's not just not getting enough sleep. Here's an incomplete list from the ICSD, which is the International Classification of Sleep Disorders, really long, boring textbook of sleep disorders. But you will see that there are many, many more sleep disorders than just I have apnea, which is a common one people talk about, or I have insomnia, which is another common one that people talk about. So if you do worry about sleep, it's important that we actually evaluate it to make sure that you're being treated for the right sleep disorder, which actually, for me, is an important question for folks here to consider. And if it's all right, Ali, if you don't mind sending out this poll question to the audience, which is, I'm curious, when was the last time that your primary care provider had asked you, how is your sleep? If you don't mind answering that question. The options are at your last visit with him or her, within the last year, 5+ years, and never. Now, I will say I expect this to be a slightly skewed sample because obviously folks in the audience here at Lown are going to really prioritize their health. So hopefully they've got a great PCP in their back pocket as well. And we can probably end this poll now, but looking at the answers, it looks like about half of you have been asked within the last year, which is fabulous. And about half of you have actually never been asked, or it's been years and years and years. And in this case, this is, as I'd indicated, actually better than I generally see in the community. But that means that for half of you, that's something where I think, hopefully you understand and buy in, that really matters. It hasn't been touched upon. And that is a real concern. Now, for that group, certainly would be worthy to think through some of the questions that I'm going to pose next. Sleep disorders are common. In good primary care data, about 61% of patients in a primary care setting have at least one issue with their sleep. So it's very likely that if you are an adult in the United States, this is something your primary care should know about. In terms of how to really think thoroughly about sleep, the kind of evaluation that I might do during a visit will go through things as I've outlined here. This is not feasible for any other provider like your primary care to do in their visits. It's just simply way too much time. I'm going to talk about a short evaluation that you can do right now or after our conversation today, but this is the extent to which we think about sleep. Everything needs to be uncovered in order to understand what it looks like. So we talk about your primary sleep complaint, when it occurs, the severity of the issue, if there are precipitants for your issue, if you struggle with breathing, if you're moving, if parasomnias occur, what consequences there are during the day, what kind of sleep hygiene behaviors you practice, what kind of treatments you've had previously specific to sleep. If you have psychiatric or medical comorbidities that are commonly overlapping with sleep disorders, and what kind of medications you might be taking that impact sleep. All of this stuff is stuff that we would be wanting to talk about. And again, likely not feasible for most primary care providers, but that's the depth of conversation that should be had if sleep is a potential disorder for you. But for folks here, just enough list of questions for you to be thinking about. Do you have difficulty falling asleep when you go to bed at night? How often are you waking up during the night, and about how long are you up for? What time are you typically going to bed Monday to Friday, or work days, and Saturday and Sunday, or non-work days? During the night, are there things that happen? Like, do you snore? Do you move? And how do you rate the overall quality of your sleep? And it's a very subjective experience. And after all of this, then the question is, if enough stuff is endorsed, then this is warranting that further evaluation that we had just covered within the past 2 slides. Now, one particular disorder that I want to focus the rest of our conversation on is insomnia. And in this case, it's because it's often mistreated in the community. Now, I want you to understand what insomnia is. The top 2 headings you see here stand for Diagnostic and Statistical Manual, or the DSM. It's another manual that categorizes disorders. The one on the left is 4 text revision, which is an older version, and 5 is the current newest edition of the DSM. Why I'm highlighting this is because the diagnostic criteria has actually changed, and actually the nomenclature has changed too. So in the older version, the DSM-4, it was called primary insomnia. Now that doesn't exist anymore. Now it's called insomnia disorder or chronic insomnia disorder. And why that matters is historically, we used to think a lot that insomnia was either primary or secondary. By that I mean primary, it's its own issue. Secondary is that it was caused by something else, like say depression or pain. And the reason that that word got dropped in this newest version of the DSM is because we're seeing so much literature which tells us that even if you treat the depression, even if you treat the pain, even if you treat the whatever else folks believe is causing the insomnia persists. It is a primary disorder much more often than not. And so folks spend months and years pursuing treatment for everything else that ails them, hoping that it improves their sleep, when in reality, now what we know is treating the insomnia first likely makes those things better rather than vice versa. Other things to highlight, and this is the diagnostic criteria, certainly won't be a test on this at the end of the conversation. What I want to highlight is it's primarily related to difficulty initiating or maintaining sleep. For both cases, that hasn't changed. In the DSM-4, it had to be at least a month. In the DSM-5, now they're saying 3 months. This really doesn't matter for most of us. If you've been struggling with insomnia, it's likely that you are well past 3 months before you're ending up seeking care. And in my case, if it's been 2 months, you don't need to wait another month of suffering before you get there. I would like to argue that treating it earlier is easier than treating it later, but just to let you know that these are the differences. And finally, I'm drawing your attention to this idea that the sleep difficulty only needs to occur 3 or more nights per week. That's a really, really low bar. That threshold is much lower than people generally think of it as. Folks often think, oh boy, I need to have miserable sleep all the time in order to have insomnia. And here, what I hope you see is no, 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 no. It just has to be as low as 3 or more times per week. Now, in terms of how you would treat insomnia, this isn't a poll question because I don't want folks to try to jump ahead a little bit here. What I do want to do is highlight what many providers in the community, so your primary care primarily, will often be saying, and what they're telling us in a study that was done a number of years ago, and I would argue recently the data has not changed substantially. First is they would recommend sleep hygiene. Second is relaxation exercises. Third is a sleep study or PSG, polysomnography. And fourth is psychiatric treatment, which really just means medications. And there are issues with all of the above. This was a wonderful review that was published now it's about 18 years ago by Ed Stepansky and James Wyatt. And what they did was they looked at sleep hygiene for the treatment of insomnia across many, many, many different studies. It's something that's called a systematic review. And what they concluded was that the wide popularity of sleep hygiene recommendations is out of proportion to the data demonstrating the efficacy of this approach, which is a really scientific way of saying it sucks. It's useless. This is what Google tells you to do. And it's not a surprise that your sleep continues to struggle after you've done everything that they have said to you online, like turning off screens, avoiding coffee after 3 p.m., and all of that other good stuff that you're being told. So don't be disappointed if that is what you have trialed previously. The next thing that was recommended is polysomnography or a sleep study. And that's actually not indicated if you have just insomnia. It's for things like apnea, periodic limb movements, if you're worried about narcolepsy, et cetera. And these are all things that your providers at Lown can assist you in talking more about, but it's not actually used for the diagnosis of insomnia, which unfortunately, I get many patients who were referred for a PSG for insomnia evaluation. Another treatment that's often used is prescribed medications. Dr. Burdich, who had actually given a talk here through Lown previously, had done a study a couple of years ago looking at the prescription medication used for insomnia in a national cohort. And what she found was that 1 in 5 American adults had taken something prescribed or over the counter for insomnia within the past month, which is astonishing because the options are somewhat concerning. Now, there's a time and a place for medications for insomnia, 110%. I want to make that clear. However, what we often see is that folks who are taking a prescribed medication for their sleep disorder, insomnia in this case, they're taking it 5-10 years after they've started, when we know that these are short-term solutions, not long-term solutions. And there's a number of reasons for that. We know that it affects driving abilities, fall risk. We worry about cognitive issues and even some data related to mortality with the use of medications used for sleep. And then folks think, well, then you know what? Over the counter is the answer. It has to be safe. My body produces this. And in fact, it's often heavily recommended. So something like melatonin, for example, I see this all over the shelf at CVS and Walgreens. Well, a couple of years ago, a group up in Canada, what they did was they simply went into pharmacies and pulled this off the shelf because, as you know, this is not a federally regulated product. I could, if I had enough power, I suppose, bottle whatever I wanted to, and if I could convince CVS to sell it, labeled the melatonin, there is actually no body that has the authority to make me prove it's melatonin. And in this case, what they found was exactly that. Not that people like me were just magically throwing things in a bottle, but that the melatonin content was not exactly what we thought it was, that there was high amounts of variability, not even just between brands, but within different lots of the same brand, and that serotonin was found in a number of these samples, which is understandable because it's actually a precursor to melatonin. But at the same time, these aren't things that people are thinking I should be ingesting all the time anyways. And also there is very limited data to suggest that melatonin is a very strong soporific agent, meaning that it doesn't do a fantastic job of putting you to sleep or keeping you asleep, despite the fact that this is what the OTC industry wants you to believe, fortunately or unfortunately. Also, we talk about things like worry of anticholinergic medications, especially the first gen ones. So these are things like Benadryl. There's a really nice article that the Harvard Health blog had published on this, where essentially the takeaway was that taking these kind of OTC medications is potentially associated with a higher dementia risk. So these solutions are not great, especially in the long term. As I said again, in the short term, absolutely, with a thoughtful prescriber, there's a role and a place for all of this. But 6 years later, absolutely is something worthwhile to consider discussing further, because these are often what I consider symptom maskers, right? If you take, say, an Ambien for your insomnia, well, what happens the day you stop taking it because you forgot it at home and you didn't take it on the plane with you? Well, you're screwed. It doesn't address the underlying reason why your insomnia exists. And that's why the American College of Physicians, the American Academy of Sleep Medicine, and many other bodies have actually come out and said all adults with insomnia should be getting something called cognitive behavioral therapy for insomnia first, not after medications fail, not if they forgot their prescription, but first. This is what you should start off with, is this thing called CBTI. Now, CBTI is effective not because of one study. We're talking about many, many studies over decades. This was another meta-analysis that was done comparing it to medication. And what we see is comparing pharmacotherapy or medications for insomnia versus this behavioral therapy for some things like sleep latency or how long it takes you to fall asleep. You see that this does better. You're falling asleep quicker. If we talk about things like how much you're awake after you fall asleep, this does better, as well as subjective ratings of sleep quality. CBTI does better time and time again. That's why these recommendations were made, is based on data like this. Now, for what you might think this looks like, I want you to throw out your preconceived notions if you've never read about CBTI before. People often think this might be CBT because it's the same letters, cognitive behavioral therapy or CBT, that might be used in describing things like CBT for depression or for an anxiety disorder or PTSD. And the CBT part is a little bit misleading at the beginning, because remember, it describes cognitive and behavioral skills, but it's specifically applied to insomnia. So treatment with CBTI looks very different than CBT treatment for depression or anxiety. They use very different skills and very different tools that you develop. And so in this case, if you've done CBT before for another mental health struggle, fabulous, but it is not what is done for insomnia. I'm going to give you a look at what it looks like. Now, the original trials of CBT for insomnia delivered 6 to 8 sessions over about a 6-month period. What I typically find in my clinic is I see folks for about 4 visits over a 2-month period. And simply because they get so much better at the end of that, that they have no more interest in hanging out with me, which is a wonderful thing, because then they have the capacity and the skills to change their sleep in the long term in as short a course of treatment as 2 months. So this is not you going to talk to somebody for years and years. We're literally talking, if you started today, that by the time you get to April, you should be sleeping substantially differently than you do now. In fact, if you actually started today, it would be the case that by Valentine's Day, you would be sleeping substantially differently. That's how fast this work is. These are the core components so that you know. First is sleep restriction, which is briefly matching time in bed to total sleep need or duration. Stimulus control, which is using your bed only for sleep. Sleep hygiene, things you've thought of, behaviors that affect sleep and improving those. Cognitive therapy, which is addressing the thoughts that you have that make sleep harder. And relaxation exercises. I'm going to go through that right now, actually, in more detail. The first element that wasn't outlined on that recipe list is collecting data. And people now think about, well, what about using Fitbit, Apple Watch, Whoop, Oura Ring, et cetera? There's tons of options out there. And what I say to folks here is actually, right now, maybe not a big red X, maybe like a light red X. And a part of this is because these devices, they go through such short life cycles, right? Like the Apple Watch is the Apple Watch 7 right now. I don't even think you can buy an Apple Watch 5, which 3 years ago was their brand new model. So the speed of science isn't that fast. We're not as fast as these technology companies, which need to make something better and shinier and funner for you to buy and spend another $330 on. And so by the time that a scientist has validated the Apple Watch 5, I'm not picking on Apple here, but has validated whatever device, whatever wearable, well, by the time they validated that against what we consider to be gold standards, that product is likely not even available for purchase anymore. And so we see as a result of things like that, like for example, here against Fitbit, a couple of years ago, a group of lawyers actually sued Fitbit because they claim that these devices don't track sleep as represented to consumers. Now, I'm not a lawyer, but I don't know many lawyers that like to file frivolous lawsuits that they can't or they don't believe they can make some money on. And in this case, this highlights the worry that I have about consumer wearables and how they relate to your actual sleep. They're perhaps a tool that we can use in addition to what we do right now, which is a sleep diary. I'll show you that in just a moment. But certainly by itself, I don't love them for this reason. They could be great, but we're not sure because of the fact that we're just not fast enough to validate these. But perhaps into the future, because those devices, by the way, collect much more data about you and give you a better way of assessing sleep than many of the things that we use in our sleep labs. It just, like I said, again, we just haven't caught up to that yet in terms of validating the devices. Now, this is what I use in my clinic. One of these 2 sleep diaries. The top one is a visual one where you're shading in when sleep occurs. The bottom one is a text-based one where you're writing about what occurs. And it's decidedly a 1995 approach, but it's really simple. And because insomnia is actually defined by your subjective experience with sleep, it is exactly what we need for assessing your sleep and tracking it before we then intervene. The first piece of CBTI is sleep restriction. What it essentially is, so that you can appreciate it, is utilizing something called sleep debt. Now, sleep debt is this thing that we all accumulate every minute that we're awake. And then as we sleep, we spend that sleep debt. What we want to do is to hoard sleep debt, as much of it as possible, and then dispense it during the right times. And in this case, what I want patients to do is to actually experience true sleepiness. And for folks with insomnia, the word sleepy is a word that you don't know well. Folks who can't fall asleep at the beginning or the middle of the night are likely going to bed tired but wired. You cannot fall asleep. Like, so you go to bed at 10 o'clock tonight, you're laying there until 11:30. You went to bed at 10, tired, you're exhausted. It's a long day, but you were not sleepy. These 2 people in the picture are sleepy. And for many of us, we've had that happen before. Like if you think back to when you had to pre-COVID catch a 6 a.m. flight out of Logan, and you woke up at 3 a.m. frantically making sure that you packed away your toothbrush, you hopped in the Uber and you got there and you're sitting there at gate B12 holding your Dunkin', dozing off at 5:15 a.m. waiting to board. That's sleepy. That's what I want people to feel when they go to bed at the right time, however, rather than inconsistently throughout the day. Now, how we figured this out to operationalize it, I asked folks to keep sleep diaries. This is an example of a sleep diary that a patient had kept. And in this case, this patient was sleeping about 7 hours per night, and they were in bed for almost 9.5 hours trying to get that sleep. If we divide 7 by 9.4, that gives us a percentage. This is their sleep efficiency, 74%, which means 74% of the time that they spend in bed, they're sleeping. That means that they're essentially wasting a quarter of their night or 2.5 hours on average every single night not sleeping. And in this case, this particular individual said that they needed to wake up at 7 o'clock a.m. for sleep. And so what do? We establish a sleep-wake schedule for this individual of 11:30 p.m. till 7 a.m., which is a 7.5 hour window. That window is enforced every single day. And the reason for this is because I want patients to buy into a mantra, which is it's not about tonight and may not even be about tomorrow night, because that's the trap that folks with insomnia get stuck in. They're so consumed and worried about how they're going to feel tomorrow that they spend more time in bed today, especially if last night wasn't good. They might go to bed early, they might take a nap, they might sleep in longer because they feel so exhausted. They want more sleep for tomorrow. However, that behavior then perpetuates that cycle that they're often in, which is a couple of nights of not enough sleep, followed by a binge night where they get way too much sleep, and then back to not getting enough sleep. So the goal for me is to turn that completely around and have patients worry about how they're going to sleep in 2 weeks, not in 2 days. And in this case, many patients go, oh my God, how am I going to function? I can't do this. And it really is the case that they will be shocked to see that they've lived through months, if not years, or even decades of this experience. They've had much worse sleep and functioned. They still show up to work. They're still parents. They're still grandparents. And they do just fine. It's just that in this case, because I am forcing them to think specifically about sleep, to do something about their sleep, that they worry. And that's normal, actually. The second piece is something called stimulus control, which is using the bed only for sleep and nothing else. And folks often think that this relates to not using electronics in bed or reading in bed. And while those things certainly are true, because what we're trying to do is to dissociate or decondition your bed as a place for anything other than sleep. We want it just to be paired, sleep, bed, nothing else. We don't want anything else to be done in there, but I worry the most about something that is called sleep effort, which if you have insomnia, you know exactly what this means. This is the experience of laying in bed miserable, trying desperately to fall asleep for hours, often for folks with insomnia. And what I say to you right now is, okay, it's 3:30 p.m. I will give you $20 if you can fall asleep in the next 5 minutes. And you're probably thinking, well, how's this guy going to find me? Well, I promise you, if you try now, I'll Venmo you $20 if you can fall asleep. And unless you have narcolepsy, it's a bet that I'm not going to lose. Now, it's because you can't just flip a switch. There's no ability to consciously initiate sleep. The thing is, this is true at 3:30 p.m. and 3:30 a.m. But many of you, if you have insomnia, at 3:30 a.m. will be laying there trying to find that button to fall asleep. And all you are achieving is driving yourself crazy. You are increasing your level of arousal because you are so worried about not sleeping. And it is only making it harder for you to fall back to sleep, therefore perpetuating the insomnia even worse. The third thing is sleep hygiene. This is a list that I'm sure you are familiar with, which means things like getting rid of a bedroom clock, being more physically active, etc. These are all things that are good. As I said earlier, though, if you do all of this, do I believe that you will cure your insomnia? Probably not. For some of you who may not be at the full-blown insomnia level, yeah, it can likely improve your sleep if you are doing some of these things really, really poorly and you do this stuff consistently, and it's one of the issues. Again, none of this stuff is meant to be or things that are bad for you to practice. It's just I don't want you to feel frustrated if you do all of these things religiously and you still have insomnia. The fourth piece relates to cognitive work that we do, including specifically in this case, setting appropriate expectations. Now, if you recall earlier on, I showed you all those slides about how short sleepers had adverse health outcomes. Well, it's actually also true for long sleepers. So we see it's a U-shaped curve that the lowest risk for health issues is right in the sweet spot in the middle. Too little sleep and too much sleep are both actually potentially harbingers for bad things and bad outcomes. In this case, if you look and you're, say, a 70-year-old adult, if you're sleeping between 5 and 9 hours, it's actually possible that this is the right amount for you, which is a huge range. It's a massive range. And everybody is different. I often get patients who have parents, grandparents, aunts, uncles, who all tell them, hey, you know what? My whole life I've slept 5.5 hours. I wake up, I feel great. I get through my day. And they're worried that they're only sleeping 5.5 hours. Well, it actually may be the case that you've been blessed and you just can get more done in the day than I can, for example. And I just need more sleep. Again, in this case, if you typically get shorter sleep, it doesn't again mean something is wrong, especially if during the day that there are no consequences of this. So here it's important for folks to understand that more again is not better. The right amount is better. And then in terms of relaxation exercises, there's a variety of ones that you can practice. I'm certainly not going to suggest that you do any one of them and that you must do any one of them. But what I will say is the worst thing you can do is to do a relaxation exercise 15 minutes before bed, purposely wanting to fall asleep at the end of that. Because that, again, is sleep effort. It is trying to do something to cause sleep to happen. It will only lead to frustration. What I do want you to do is perhaps the 15 minutes before bed, practice a relaxation exercise because it makes you happy, it makes you feel calmer, it makes you feel better. And in that situation, you will actually be more likely to fall asleep. So a slight distinction there, but it's important to consider why you're doing that activity. And then also a reminder for folks that sleep occurs in the context of a range of different things. I've heard somebody say before that if you flip open a dictionary, point to a random word, that word can probably affect your sleep tonight. That's how sensitive sleep is. It's often a canary in the coal mine for other issues going on in your life. That means it's important to not overthink sleep on any individual singular night. It could have been disrupted because of medical issues, because you got into a fight with your spouse, because you have young children, because it was hot and the AC broke, or it was cold and your heating system broke, because you're exhausted from working, because the Pats are playing on Saturday and you really want them to beat the Bills. There's a million reasons why you're not sleeping tonight. That's not an issue. It's if this is consistent across all of these contexts, that's when we want you to think about more and more of it. Now, I appreciate that I ran through everything as fast as I could, which means I hope that there's going to be an opportunity now for questions. But importantly for this group, if you do want to learn more, there's a number of really good books. You can go online and buy pretty much any cognitive behavioral therapy for insomnia book. It'll tell you what you need to know. Don't be disappointed, though, if you read a book and you can't practice it by yourself. It's like for many Americans, if you want to lose weight and you buy a book, it's really hard to do it right sometimes. Other resources. The American Academy of Sleep Medicine is a wonderful body for finding accredited sleep centers that may be able to do sleep studies for you. The Society of Behavioral Sleep Medicine is a wonderful resource for finding providers that specialize in CBTI. Remember, again, that is separate from traditional therapy. So our take home today, sleep problems are incredibly common and often may require somebody who specializes in this to evaluate you, especially if you're worried about multiple things that we had talked about checking off on our checklist earlier. The good news is many, many sleep problems can be treated very, very effectively without things that are commonly used, like prescribed medications, though some may require them. And if we're talking about insomnia, behavioral sleep medicine for insomnia or cognitive behavioral therapy is not standard therapy and will require somebody with specific training in this work to be able to walk you home. So I appreciate the opportunity to chat to this group, and I'm really looking forward to what questions you may have for me today.
Bravo, that was wonderful, Eric. Thank you so much. I learned so much from that conversation.
Thank you.
I'm wide awake, Dr. Bilchuk.
That is a wonderful background.
Eric, you owe me $20. I'll send you my Venmo. No, I stayed awake through that whole talk. I have to say, thank you so much, because this is so incredibly helpful. And it's uncanny to me how much I learned, and I thought I knew a lot about this area. So thank you again. And you just took us through quite a journey, and I appreciate it. Just a quick comment, we at the Physicians Council at the Brigham dealing with physicians' health, and we had a whole wellness initiative, and sleep being one of the biggest issues. And the demand for your talks and the feedback that we got about sleep was just incredible. And, you know, we are really poorly trained in this area. And I just wanted to, you know, thank you, commend you. I was intrigued by the sleep charts that you give people. And I'd love to actually have a copy so that we can utilize. We use arrhythmia calendars. We use blood pressure calendars to see what the patterns are, to see how we can kind of interact with people and help modulate change. So I just wanted to say that. And the other thing is, it's so hard to get to see a sleep specialist. So how do we do that? You know, when someone has sleep apnea, we have a fairly clear kind of idea of what the protocol is. But as clinicians, how do we get people to see people like you when the wait time is incredibly long and there's such a shortage of people like you and experts? So thank you again.
I appreciate you staying awake, Dr. Bilchek. I will say, if you noted, one of the criteria for being diagnosed with insomnia is sufficient opportunity for sleep. For many physicians, that is simply not true. So I can't help you there, unfortunately. In terms of being able to address this issue of a lack of providers, if I had a good answer for that, I'd be much richer than I am. It is absolutely a devastating challenge for many folks in this country. I would add two thoughts to that. First, the pandemic has brought about a wonderful increase in comfort and patient comfort with telehealth. And this has meant that I have a number of patients who come from Western Mass that never would have otherwise been able to see me, but because they can only see folks like you, now they say, hey, this actually isn't so bad. So this is promising, in that it means that within the state that you're in, you can likely find, I hope, a provider who provides telehealth and you don't have to drive. The Society of Behavioral Sleep Medicine website offers lists of providers that you can check out if you're not in Massachusetts. Alternatives are online programs. So there is one, and I don't want to endorse anything since this is recorded, but there are online options, including one that is FDA approved, so that you can prescribe it to your patients, and it's possible that their insurance will actually cover it. These are automated approaches. It's not videos, it's actually interactive. You keep diaries, it provides specialized, individualized feedback to patients. And I've had the privilege of working with the developers on a couple of different iterations for my patient populations, which happen to be at the Dana-Farber Cancer Institute. And it's such a beautiful way of increasing access. Now, granted, this requires that somebody is very motivated to do the work on their own, but they do essentially have a computer-based therapist, and the data shows that it's as effective, if not better, than what I do with patients individually.
Well, I think that raises a lot of interesting, questions about just awareness, and I think, you spending so much time talking about kind of the health-related problems at the beginning of your talk related to insomnia and lack of sleep, right? I think we're seeing that this is finally getting its due airtime, right, in terms of recognition of how, what a serious health consequence sleep deprivation is. So hopefully treatments that are accessible are to follow. We're lucky in the Boston area, though, that we do have access to you and a lot of local doctors. So there were a number of questions in the chat about just finding your practice or finding somebody like you. I'm assuming we'll share your contact information in terms of insurance coverage. How does that usually work for people that want to do a session with you?
So my understanding is that there are providers in the community that are insurance paneled. As many providers who do this work are mental health providers, it might mean that the wait list to see them if they're insurance paneled is slightly longer, which is an unfortunate issue right now during COVID. At my hospital-based clinics, they are insurance-based. And so if you do have a history of cancer and are treated at the Dana-Farber, you can absolutely see me there. And if you send me an email, I'd be more than happy to connect you with my scheduler there. If that's not the case, as you had mentioned, Dr. Kelly-Hedgepeth, I am not an insurance-based provider in private practice, but for folks who have certain types of healthcare plans, like a PPO, they can submit for something called out-of-network reimbursement, which is a potentially viable option to see providers, not just myself, but others who may offer this service that are out of network and not paneled.
Great. So we'll make sure we'll share that with everybody in the follow-up email. There seems also to be in the chat a couple of questions just about melatonin, and a request that you maybe just simplify what you said and give us again that bullet to the take-home message.
Yeah, so the take-home messages for folks to consider. First, there isn't a lot of compelling randomized trial data to show that it helps people, typically developing adults, fall asleep and stay asleep much better than placebo. That's important because there's actually a very real placebo effect to anything that we take for sleep. So if you take melatonin right now and you believe that it helps your sleep, I strongly encourage that you continue taking it. You have no argument from me. But if you are taking it and it has not worked, I wouldn't be astonished. The second takeaway is that it's probably not too harmful for your health. You don't stop producing it if you take it for a month or a year. It's likely just means that your urine is very expensive in the morning because you will excrete it, and it likely won't have improved your sleep. But there really aren't too many worries. Ideally, you're getting something that is either compounded at a pharmacy that you can trust, or hopefully in the not too distant future has some sort of a quality control mechanism to make sure that it is exactly what you are buying.
Great. I'm going to jump in with a question from the chat as well. And I first want to say thank you so much. This is a topic that I think affects every single one of us, some more than others. I find that in my older patients, sleep becomes a bit more fragmented, so that the sleep isn't all at one chunk at night, but maybe with naps in the day. What do you feel about naps? Is that okay if it's working for somebody? And attached to that is, if it's working for you and you feel good and you have energy, does that mean you're getting enough sleep and good quality sleep?
Yeah, wonderful questions. I would say the nap question is one that we get a lot. And my answer to that is it's like chocolate cake. In moderation, it's perfect. It's delightful. It feels good. And if there's ever a case in which you worry about the excess, then probably not. It's probably been an issue. So plenty of good sleepers take a nap, often in the afternoon. The difference is those naps tend to be consistent in terms of duration, and they're usually short, like 30 or fewer minutes, and at around the same time of day every day. That's the pattern that we see in good nappers. For folks who find themselves napping anytime between 12 and 6 p.m. for sometimes 30 minutes, sometimes 3 hours, those tend to be what I consider recovery nappers, that they're so exhausted that they can't function without that nap. And that's a bigger sign that their sleep is very dysregulated. And that's where I would say no. And as you're saying, Dr. Lee Lewis, in the evenings for older adults, they do tend to have more fragmented sleep. We do see the number of wakings increasing as we get older. Those are normal events. In fact, if you are 30 and you wake up 2 times a night that you can recall, I should add, people wake up much more than that. If you had a sleep study done, we would see you are not waking up 2 times a night at 30. You might be waking up 5 times a night at 30, but you don't remember all 5. In this case, waking up a couple of times, going to the bathroom, falling back asleep within a couple of minutes is completely normative. And that number increases as we get older.
So I thank you again, but I love the fact that you address the issue of wearables, because these devices, and I'm actually just trying out one of these Whoop devices, and it shouts at me every day that I don't get enough sleep and my recovery time, and and it's just it does help with some behavioral modification, and it does potentially aid with patterns and recovery and all the other wearables as well. In cardiology, the same thing. There's sometimes just too much information, and the more you worry about these things, and the more you lie awake worrying about falling asleep, the less likely you fall asleep. So, the notion of sleep hygiene and the way you kind of articulated that, and even your charts of what is normal is so incredibly helpful. I know I'm going to watch this again and again, and because I felt that it was so rich with data. The other point about the lack of control really of all these supplements that we see. I mean, it's staggering, 400% more than the dose versus 87% less with the melatonin. And then there's all these newer, this not CBT, but CBDs and marijuanas and sleep aids. And, the concern about the habituation and then the addiction to sleep medications and how to get off them, which is another whole topic, I'm sure. And one of the struggles is how to get people, into that sleep hygiene mode. And a lot of this is therapy and repetition. So again, I just appreciate it. I don't know that there's anything within there that's a specific question, but lots of comments.
Thank you, Dr. Pilczyk. I'll answer the question that you didn't ask, which is about cannabis and cannabis-related products. That's often a question that I get from the audience. So if no one's asked that, I'll answer it for the group. It's an industry for which, as you hopefully know, the science has been greatly outpaced by growth and legalization. We have a very poor understanding of the effects of CBD, THC, CBD/THC, how it's consumed, what dosage, what strain on sleep. It doesn't mean that it doesn't work. And I again say to folks, if it works for you and there are consequences that you're okay with living with, I certainly cannot tell you not to do it. The bigger worry that I often have for patients is related to the legality of these products. So if you're visiting your cousin in Houston, you can't just walk into you can't bring it on your plane, and you can't just walk into a store and buy a THC gummy and sleep that night. So that's why I encourage folks to, if this is your only mechanism to sleep, to consider alternatives.
And along those lines of medications that might help or supplements, what about valerian? That's the question.
Yeah, Dr. Burdich and I had written a review of the data for this very question, and there's just not a lot of good data on this, and the data seems pretty mixed at what we did find. But as I had said earlier with the melatonin, there is a true placebo effect to sleep and a substance that's used that is designed to potentially help sleep. And so for everyone out there taking valerian root, and it works, keep taking it.
So just to summarize, what I'm hearing from you is that there's downsides to medications and supplements, and not clear science showing a proven benefit for a lot of things. The other takeaway I have, that we need to give some thought and effort to our sleep routine and our sleep schedule to really help us to understand if we're light on sleep, adequate on sleep, or being honest maybe with ourselves and our lifestyle as far as that goes. I personally have found that wearing a sleep tracker, even though the data might not be anywhere near accurate, forces me to make it a priority. And I think that is really important, because I think most of the teens and adults in this country probably chronically are sleep deprived on a regular basis. So
that's a wonderful point.
Yeah. Okay, well, here we are at 4 o'clock already. So this was a wonderful discussion, and it will live on our website for anybody who wants to watch it again or refer family and friends there. Eric, thank you so much for this wealth of information. We will be sending out an email with contact information and also a post-webinar survey. So we encourage all of you to fill it out for us. And we thank everybody for joining us today. And we'll see you again in a couple of weeks.
And I think if we didn't get to all the questions, there were so many, there were 100 people on our webinar today, but maybe what we can do, Eric, if it's okay with you, is shoot you some of them, and perhaps at least the quick ones you could answer in a quick email.
Will do.
Thank you.
Take
Thank
care.
you so much.
Thank you so much.
Sleep well.